Hello, and today we're joined by, and we're actually very honoured to have a clinical neurologist from the Perron Institute. I hope I've said that right. David,
Okay.
thank you, and welcome to the show, and thanks for joining us.
Well, thanks very much, Luke. I've been busy listening to your podcast lately, and I think we're on the same page in terms of exercise, and it's really become a passion of mine in the last few years.
Yeah, that's wonderful, and it's just great to hear there's some alignment between some of the educational material we're trying to produce, and obviously some of our courses and the content within them.
Yeah.
So,
Yeah.
could you tell us a little bit about your background, Dave, and how you actually became interested in Parkinson's disease and exercise research? I suppose would be a great place to start.
Yeah, well, look, I've been a practicing neurologist and a clinical researcher for more than 30 years now, and my main initial work was to do with stroke, and I've been involved with all angles of stroke, right from the basic science lab through to rehabilitation. And I did a fellowship in the US in the early 2000s, and that was the time when clot-busting medication and intervention for stroke was really coming to the fore. And the very month that I came back to Australia in August 2003 was when the clot-busting medication TPA was approved for use in stroke. So my main thing at that stage was really organising stroke services and getting these new treatments up and running, and it really was a very exciting time. But concurrent with that, I also had a period where I worked in neurorehabilitation for 10 years at the Royal Perth Rehab Hospital, otherwise known as Shenton Park, which is a fantastic facility where we'd had 30 inpatients, many with stroke, but with other neurological conditions, such as multiple sclerosis, and they'd have very intensive rehab. And I was particularly interested in looking after young stroke. And it was there that you could really see the benefits of mobilization and exercise. You could see global muscle mass loss incredibly. For every week sitting in the acute hospital, you could see the muscles melting away. And I was starting to get interested in some of the basic science around then as well. And I was struck by the fact that in experimental rat and mice models of stroke, there'd be up to a 30% loss in muscular mass. Not just in the paralyzed limb. It was a global effect, and that was interesting because you could actually see as the patients. There are two facets you could see. You could see the paresis involving, and the physios would help to guide that. But you could also see the general musculature starting to improve. And frustratingly, there are no shortcuts. And to this day, there remain no shortcuts, no stimulants, no pharmacological impetus that hurries things along. In the end, it comes down to good old-fashioned hard work and motivation, and there's a whole layer of psychological stuff on top of this. So my background then was really out of the rehabilitation sphere, and kind of at the same time, I was trying to look after my own health a bit better. I'd always been sporty. I'm very keen golfer, remain keen golfer to this day, and swimming, and was a swimming coach for a while to support myself at uni. But then comes the busy hospital time and young family and things, and all of a sudden, 10 years go past and I haven't done much exercise. And I'm sitting in the clinic telling people to healthy lifestyle, exercise, etc. after their stroke, and wasn't doing it myself. And that's when I started to get into running. I'd never been a very good runner, but you did it as part of hockey training and as an adjunct to sports. But I really got hooked into it, and I found I'd get up super early in the mornings, and it wasn't long before I got into the whole training regime and wanted to do a marathon, and I ended up doing 6 marathons over the course of about 2 or 3 years in my late 30s to early 40s. And I just loved it, the feeling of getting your body just right, and hooked on the endorphins, I think. And so the next chapter of the story then starts to alter a little bit. As I was running more and more, I started to get what ultimately was diagnosed as an exercise-induced dystonia. And that's a neurological condition where there's an involuntary twisting and contraction of the musculature. And that can occur as an independent condition, but it can also be the forerunner of Parkinson's disease. And it can be the forerunner of Parkinson's disease by many years, in fact. And so initially, I'd only had the trouble really in the latter phases of the marathon, where a lot of stuff's happening to your body when you're crunching through the wall. But then began to happen at shorter distances and shorter times. And I noticed that if I was not running steadily, if I was trying to sprint a bit towards the end of a race, my leg would go off. And so I had to sort of modify things a bit in terms of my exercise, because I realized that the more that it was actually limiting my ability to compete. And I was never a very good high level runner, but as you get older and you enter older age groups, you're the youngest in the age group, and you think, oh yeah, you might get a chance to top 10 in something. But it was all going the other way. And then we'll fast forward a bit more, and then in the mid-20 teens, it was only then when I started to develop some of the other symptoms of Parkinson's. And by 2016 to 2018, I was starting to have trouble with handwriting and an intermittent tremor and slowing down. And I was having trouble, and all the time I'm sort of trying to play as much golf as I can. And I started having trouble putting the ball on the tee. Could still swing all right, but it was actually the little movements that were difficult. And then in 2018, it was really starting to affect my work. In fact, it was hard to get around, hard to take notes. And I would look back at my patient records, and you could see my handwriting deteriorating over the course of years. I followed them up, and you could see the small handwriting. So in the meantime, that was a very strong motivation to learn as much as I could about how Parkinson's could potentially be slowed down. And whilst at any given time, really over the last decade, there's been upwards of 40 different drug trials and device trials going at any given time, many of those supported by the amazing efforts of the Michael J. Fox Foundation, we're as yet to find a winner in terms of pharmacological slowing of the progression of Parkinson's disease. But right under our noses is the fact that there's accumulating data to suggest that early exercise is a really important part of Parkinson's disease management, and may in fact be beyond symptomatic benefit, may in fact really be something that actually slows the natural progression of the disease. And I can pause and we can launch into that, but that's where I really got excited. And because running was my main route of exercise, and that was now limited by my dystonia, I had to start to get a bit more original and start thinking about other ways to exercise. And so around that time, we're getting into the sort of 2019, into the pre-COVID era. And I tried a few other things. I went back to swimming for a while, but that's not really good when you're an on-call stroke doctor and you're out of contact. Tried a bit of cycling, tried just slowing down my walking, and tried a little bit of interval training. And I'm never very, very keen on interval training. When I was doing my best marathons, I'd devote a day a week, as per many of the running schedule and programs, to smash out some intervals. But you felt good for a while, but I wasn't that keen on it at that point. But in just before COVID, my story intersects with another fellow from Perth my age, Rai Fazio. And you probably know Ray from the combat sports world. Ray was a champion lightweight boxer, and his father was in fact in the Italian Olympic squad. And the family moved out here I think in the 60s, and he actually set up a training gym, and his father died a couple of years ago, but over the course of 50 years, he consistently trained high-level boxing, high-level boxers. And one of them, of course, was his son, Rai. So Rai started boxing at about 4 years of age, and it wasn't long before he was actually beating fully grown adults. And he became a champion in his teenage years. And it's quite interesting that Rai was a bit ahead of his time. And whilst he never really had any major knockouts, he started to get worried about the impact on his brain. And this is well before all the concussion issues that become much more well publicized. And very good podcast you did recently on that. And so Rai wanted to get out of the boxing ring, and that was a bit difficult with his fairly, let me say, harsh Sicilian father. And so there's a bit of conflict there. And in fact, Rai went on to make a movie called Two Fists, One Heart in 2008, directed by Paul Hogan's sidekick, who died a few years ago. So Rai was a pretty high-profile media character in Perth for some time. But when he got out of boxing, he really got into training. And so he set up quite a number of gyms, and one of his things was box and bike. He'd have a session where you'd have a group of patients or a group of people doing work on boxing, and then onto the bike, and then back again. He's a mad keen inventor, and as a trainer, do lots of sparring work, and he repetitively, if the boxer wasn't quite on target, the sparring mitts would fail to transmit the force, and he actually got a lot of shoulder injuries. So he thought there had to be a better way, and that's when he started to design alternatives to the big heavy boxing bag. And he went on to invent a machine called the Fight Master, and later an iteration called the Box Master. And these are machines that have got padded targets. It's about 13 padded targets that are all designed to receive your straights, your uppercuts, your hooks, all the different punches and styles that you do, and become a highly effective training device. We've got a moment I know it's a podcast, but later I'll show you my Fight Master machine set up in my front porch. But so Rai developed this machine, and in about 2016 he was attending a trade show in exercise equipment, a trade show in Europe somewhere, and he came across a academic physiotherapist named Josefa Domingos from Portugal, and she'd actually got hold of a couple of his machines and was using them to do a short study in Parkinson's disease. And Rai was absolutely blown away and delighted to see that his machine was being used for such a good thing. But at the same time, he was a bit shocked and horrified to see that she had all the settings wrong, and the way she was training, I mean, she couldn't be expected to train like a proper boxing person could train. So he's a bit concerned that potentially patients could be set up for injuring or miss out on all the possible benefits. So he became quite interested in setting something up when he got back to Perth. And long story short, through a whole series of interconnections and some common friends, we got together at the Perron Institute, like I said, the last months of 2019. And the training program that he's got, he's had pretty much a 12-week training program. If you're going to do an amateur boxing fight and you already had a little bit of fitness behind you, he had an established 12-week program. And it's a very extensive training session. About half of it's devoted really to boxing movements without any punching. It's about balance, it's about the sideways movements, it's about the in and out movements. It's about using the ring to get away. It's about staying on your feet and warming up your shoulders. And the very first exercise they do in the warm-up is really an elbow extension. bit like this. And it struck me when I saw him doing that, that a lot of the positions and postures that you require to box are almost the opposite of what happens in Parkinson's disease. So in Parkinson's, you get the forward flexion, you get the elbow flexion, and you make short, shuffling, slow, weak movements. Whereas to make a successful punch, you have to stand up tall, you have to be a little bit extended, you have to make big, rapid, strong movements. So it's all very completely the opposite. So even the features of Rai's warm-up immediately struck me as being, wow, this looks pretty good. And so he took me on and he trained me in the early days of COVID. In fact, I think the first thing that he and I learned how to do on Zoom was coaching of me from home or from the gym, and him from his home in various different lockdowns in early 2020. And and really within about 4 to 6 weeks, I could start to feel this really making a difference. And early on, the focus is really on technique and getting posture right. But then as we amp things up, what we do is our warm up, then we do rounds of boxing, learning different sequences, different sides, the southpaw versus orthodox. And at the end of each boxing round, he'd pop in 15 to 20 seconds of high intensity uppercuts, and really just going like crazy at the end of each little session. And I have to say, that's when I really felt the difference, when we added in that little bit of high intensity interval stuff at the end. And so while we were doing this, we were doing training 2 or sometimes 3 times per week. We were taking notes and trying to really see how we could modify this for patients. In the end, we only discarded a small number of the things that could potentially be a bit of a problem, such as postural hypotension. He had some exercises where he had to move his head up and down, and I could feel myself getting a bit dizzy with those, so I thought that might be a little bit problematic. But most of the exercises in his program for healthy, fit people were included, although we tried to put an emphasis on the things that we felt would benefit Parkinson's disease. Now, also around this time, I was scouring the literature, and the rock-steady boxing movement for Parkinson's disease was very big in the United States at this time, and with hundreds of centres at various gyms around the country, and thousands of participants. But if you looked at the amount of exercise science literature coming out of that, it was pretty small. And an academic physiotherapist from Victoria, Meg Morris, did a lip review in 2019, and really only came across 2 studies of value on which to base the data, and there were huge gaps. And interestingly, no one was really adopting any proper sports science measurement techniques, no RPEs, no heart rate monitoring to any of these boxing studies, which are all quite small, observational, and unblinded. Now, to add to the sort of team, Luke, you probably know Travis Cruikshank at ECU. I don't know if you come across Travis.
No, not in my travels just yet, but that might change very shortly.
Yeah, so Travis has a background in tennis, and he and one of Rob Newton's disciples, and Travis and I had actually collaborated on a few other things for post-stroke recovery. And he'd actually reviewed a paper that Josefa Domingos, the physiotherapist in Portugal, put in about boxing. And he was aware of those things. Rai and I got Travis involved with the program, because what we wanted to do is to measure it. We wanted to properly design a segmented, periodized, properly controlled training program. And and that's what we did. So once I'd sort of, Ray and I decided that we could do this with Parkinson's patients, we wanted to explore, could it be done with more than just meat, and could it be measured properly? And we decided to make it more of a feasibility study, and I almost viewed it as almost like a phase 1 drug trial where you amp up the dose and building up and up and up and seeing if there's toxicity. So I think World Brain Day in about 2020, we had a segment on the Channel 7 News, and we got a huge amount of inquiries. So we had this massive list of people, and it's important to emphasise that the program that we created was really for reasonably early stage Parkinson's disease. We thoroughly screened them all with exercise stress tests. We didn't want to explode anyone's heart, as you're well aware, and that you nicely covered podcast of yours on hits and cardiovascular risk. And the greatest travesty was we had to turn quite a few people down, and there were complications because at this stage Western Australia was really getting deep into lockdown, and we had some gym space up at Edith Cowan University, but at that stage you had quite strict limits on the number of people in the rooms, you might remember. So it was all in that context, but the ultimate conclusion was we got 10 subjects, mean age of 60, and we put them through 3 5-week blocks of training, and within each segment there was a sort of orientation to what we were doing. The first block was really focused around the technique, making sure they were in the right stance, position and posture, and gradually building up their cardiovascular and strength parameters. And we had them all with a chest strap to monitor their heart rate and Bluetooth it to their phone for polar beat recordings. And we did org scales of perceived exertion, not only physical but also mental exertion. And so the first block we built them up, and then we had a little rest period. And by the time we're getting to the 6-week mark, they're really roaring to go, and that's when we start to really pump them up. And we were very prepared to pull back on each individual should they be getting any signs of any injury or fatigue. And we were constantly measuring these with various scales and Likert scores and things. And to my great surprise, we only lost out of, I think we had something like 360 workouts that were feasible, and a few people missed due to various different COVID reasons, but we only lost 1.1% of workouts due to injuries. And they were just minor knee strains and things that adapted to some change in footwear and a little bit of anti-inflammatory. And so I had anticipated that this group of somewhat older people with Parkinson's disease would run into more problems, but they got through fantastically. And then in the last block, we eased off, and we then focused not so much on the cardio, but the cardio levels were really good. We then threw in a lot of cognitive challenges. So we wanted to start doing the dual tasking sequences where you'd be working physically, but then you'd have a mental task. And so on the Fight Master, all the different pads have got numbers for their different punches. And so we'd start off with a certain sequence, and for example, you might do it in the orthodox stance, but then you flip around to southpaw stance and then do it the mirror image, which is surprisingly difficult. And then we'd add in things like random sequences. We'd get them to try and remember up to 9 digits, so that, like I said, the number of targets. Usual short-term memory you can handle 7 digits, but when you push it up to 9, you're starting to really stretch people's brains. And so this is where we were looking at adding this cognitive load. And So the main conclusion of the studies were that this group of healthy individuals, or of early Parkinson's disease, although they're fairly carefully selected, they could safely undertake it. And what I was particularly pleased about was the practicalities, that you could actually measure the heart rate and record it. You could actually measure RPE at the end of each round, but we had a little bit where we'd have EP students have the Borg scales in front of them, and the patients would sing out their RPE, and we had all this recording. And we've still got a lot of data we're working through, but I'm pleased to say it did get published in the Physical Medicine and Rehabilitation Journal at the start of this year. And the great thing is the group of subjects that we studied have developed enormous camaraderie, and many of them have kicked on and got Fight Master machines at home. We've got one lady who had previously been a runner. She's got back to running. A number of them have even been able to reduce their doses of medication. And I can tell you from personal experience that when you've had a good hard session, there's a glorious couple of hours after that where you can move more freely. And we know that high intensity levels of exercise increase the cortical frontal pathways, make it more sensitive to the impact of dopamine. So there's a little glimpse we could get where you almost forgot you had Parkinson's for a while. And many of the patients felt that. And I think that's why they became so enamored of it. So that's a long story.
No, you've managed to hit all of the questions, almost the first page of questions. I had carefully considered the questions I wanted to ask you, and I'm just so impressed that you hit them all without me having to ask you. So thank you. You've done a lot of work. But I also want to thank you for sharing your personal journey and your story. That was very kind of you to do that. I think that's important. But on top of that, being such a wonderful ambassador, I feel, for physical exercise and physical activity in general. And it's not that common amongst specialists and medical professionals to have that history of physical activity you've had in sport and exercise, and still to this day. And I'm just so impressed, and I just think it's wonderful because we often, as exercise professionals, sometimes our understanding of or I guess communication with medical specialists isn't always on the same page, because they don't have that intrinsic understanding, perhaps because they haven't had that lived experience that you've had. And I'm just so impressed by that. It's just amazing.
Look, I think,
yeah.
I mean, Hippocrates recognized that exercise was important in medical practice all those years ago, and we've kind of really let it slide. And the typical doctors are not experts at exercise. And whilst I agree with the idea that exercise is medicine, you don't want to throw that term around too lightly, because the way that many physicians are prescribing it is haphazard and not utilising the expertise of people like yourself, and who've got proper knowledge of how to construct a program, how to go through the ups and downs, how to modify it for different levels of activity, different fitness levels, different experience. It's a very complex area and needs a lot of expertise. And doctors, we just don't have that expertise in that field. And that's why one of the great things that, as I learned as a stroke specialist in rehab, is the team atmosphere. And in rehab, and one of the things I enjoyed was seeing patients kind of starting out their rehabilitation process with physiotherapists who do a fantastic job, have got a fantastic knowledge of pathology. But then as they got a bit better, I'd often try and get an exercise physiologist involved, coming from a sports background. And there was often a lot more enthusiasm and eagerness, and it was almost infectious. So I think that the balance of a physio who's anchored more in disease and an EP who's anchored in sports and health is a really good mix for patients.
I've got to ask, David, did you run into any misconceptions from other clinicians and other specialists? And because if you think about it, boxing as potentially as a therapeutic intervention, no, it's really outside of the box, isn't it? And
Yeah,
and it's certainly, look, even amongst exercise professionals, I would add that the concept that
yes, yeah.
boxing could potentially one day be seen as a treatment modality for Parkinson's, it does seem a little bit left field if we could use that term. Have you run into any misconceptions yourself that you can talk about?
Yes. In fact, that we've kind of modified it by de-emphasizing the boxing and talking about exercise. But at the start, I mean, I had some reservations because I was working in an institute that had a big arm that's currently doing work on concussion at a basic science level. But thankfully, the administrators got it and understood it. Some of my colleagues don't to this very day. And in fact, we were looking at trying to get some access to a shared room where one of the neurosurgeons had his Parkinson's patients having film, getting film for gait analysis. And Ray and I have been training in there, and we proposed using that as our gym. But the neurosurgeon wouldn't have a bar of it because he didn't want to have his name associated with boxing. So you're absolutely correct. It's been a little bit of a difficult road, although one interesting highlight from the literature from about February this year was that Muhammad Ali's family consented to the release of his medical records. And it turns out that he didn't have traumatic-related encephalopathy. He had regular, young-onset, dopa-responsive Parkinson's disease. And so there was a misconception that his PD was related to boxing. It was just regular PD. And in fact, perhaps his boxing career ameliorated his symptoms for a while.
Is that right? That is just, yeah, totally amazing. And you're right, because that perception of a pugilistic sport and the contact side of it, I guess, is what might cause a concern, particularly amongst clinicians who do that work in the head trauma space.
Yeah. So it's a very good point.
How do we understand then, on the other side of this conversation, what is unique and specific about boxing that might potentially address some of the symptoms of Parkinson's disease? You've alluded to some of them earlier with the stretches and the warm-ups. So yeah, is there anything in your experience that you can point out?
Yes, well, I think there's several layers to this. First of all, there's that specificity of movement. Like I was saying, many of the postures and positions required to throw a good punch are the antithesis of the posture for Parkinson's disease. Second is balance, and you spend a lot of time. You see pictures of the boxers with it, and you know from martial arts, a stance with 60% on the front, 40 on the back, rocking back and forth, developing a really good, strong torso and core and balance. One of the huge problems in Parkinson's that doesn't respond to medication is balance issues. And the nightmare scenario is fall, break, hip, and the spiral of doom that follows after that is certainly a reduced life expectancy once that happens. And so the ability to move and to adjust to little bits of imbalance, I think, is extremely valuable, and that comes from the boxing. And then finally, of course, the cardiovascular impact is tremendous. I mean, it's a very efficient form of exercise, as you well know. If you compare various different exercise modalities, the bang for your buck in the time is a lot better with boxing than say running. And so, you know, I was used to having 2 or 3 hour runs on a Sunday, and now I still walk most days, but I do 2 30-minute high intensity interval sessions on my boxing machine twice a week, and that's invigorating. So it's a very time efficient form of exercise. And the intrinsic nature of it is really high intensity interval training. Once you sort of gear people up, and I've become increasingly interested in the whole HIIT's concept. Having been a skeptic some years ago, I think as you well know, in the exercise world, it became fairly fashionable probably about a decade ago. I remember the Michael Mosley, the British doctor and famous journalist and diet expert, doing a feature on it in his program. And I was a bit concerned about surges in blood pressure, being a strokeologist. But I have to say, the more and more I've looked at this at a scientific level, I think there is a certain threshold that releases the brain BDNF and other trophic factors that stimulate brain regrowth. And I remember seeing at a stroke conference some very exciting pictures of enhanced axonal connections in exercising mice and rat models of Parkinson's and stroke. And I suspect that there's a metabolic milieu that's created by high intensity exercise that that probably requires and is enhanced by things such as fasting state, perhaps also a little bit of lactic acidosis and muscle use. And I would suspect there are triggers that once you get that appropriate milieu, that probably lead to the release of the factors which we probably haven't fully identified yet. And some really exciting animal stuff out of Stanford, I think from 2001, where they had a model, or 2021, where they had a rat model of Alzheimer's, and they had an exercising rat, extracted the serum from that rat, and then put it into sedentary couch potato animals, who then accrued the benefit of the exercise. So they were able to transfer whatever was created by the exercise. And you might think, oh, well, that's a bit of a shortcut. But if you think about people with neurological conditions who can't get to high intensity levels of training because they've got paralysis from a stroke, or their Parkinson's is too advanced, that to me is a very exciting prospect. So we've spent all these billions of dollars looking at all these different medications, when it's possible that within the blood in the immediate post-exercise phase, the answer might be sitting in there.
That's, yeah, truly remarkable. That really is. So we've talked a little bit about the physiology of boxing. What about the other side of it? The psychosocial benefits, perhaps? Is there something in there as well that makes it a little bit different to conventional exercise?
Yeah, look, I think the comments from the participants really bore this out. The friendships, the camaraderie, the taking out of the frustrations, really. One of the participants said that her workplace colleagues said it wasn't a very ladylike thing to do boxing, and that really got her going even more. But 8 out of the 10 participants wound up getting machines in their home, and for about a year we continued with a weekly Zoom session on a Tuesday night, and we added a few other people to that. We've paused that at the moment because Rai his partner had a baby, so Rai was a first-time dad at 55 years of age. So we're just sort of getting back into that now, and Rai has developed a whole series of educational videos that go with the boxing machine, and we've made them quite Parkinson specific, and we're looking at being able to create some online information. We're also trying to get some gym space to get to revamp face-to-face sessions as well. So, but the camaraderie and many sports, and I think it's a feature that's integral. If you're going to maintain any exercise program, I think you have to look at factors that keep people in it and keep people engaged. And the boxing, I think, is because it's quite a different thing for many of these people. It's a completely new sport. They could never imagine themselves being a boxer, a bit like me, and now they're proud of it, and it's got a bit of popularity, and hopefully we'll gather some momentum and keep it going.
Yeah, and that's a nice segue into my next question. I guess if we put our research hat on and we want to see this move, I guess, forward, see boxing research move forward out of the fringe category, if we call it that, and to a more established or a higher level of credibility, I guess one challenge is the heterogeneity in training methods. And I think you were very lucky in that you had a wonderful boxing coach but also understood the programming side. And I've reviewed carefully your paper, and I've looked very carefully also at the detail in that progression model that you had, the periodized model. And it's just an exemplar, really, of program design. And that's very rare in boxing, absolutely rare. It's very hard to see I guess, universal agreement on what a training program per se should look like. And I guess that creates a challenge from a research perspective, doesn't it? That right now there's a lot of heterogeneity in how boxing sessions are delivered. And if you look at the research and how they've done it as well, there's a lot of variance. And do you have any thoughts on that and how that could be moved forward to get us to a point where we could one day define the optimal dose? And we're talking about dose response, perhaps around, the exact number of, or the exact volumes and intensities and so forth.
That's a really good point. And Travis has previously done work on Huntington's disease, so he's quite familiar with designing programs for degenerative neurological conditions. But it's interesting, when I looked at the literature, it also gets a bit proprietal, because people have their programs and they want to commercialize them and don't want to necessarily give you out all the details. And so it's an interesting barrier between academic advancement and commercialization. And I think that's been part of why it's hard to access. So we might be able to lift the lid off that, and simultaneously, of course, I want Ray to be able to benefit from it, because he's been extremely generous with his time and his resources. That gets back to the exercise as medicine, like you're saying, really understanding the dose, really understanding the targets. As you said, it's not really ever been done in boxing, and it's all a bit haphazard. But the Boxmaster machine, really, you could actually count the number of punches that you do. With a bit more sophistication, we could potentially even put some force pads within it as well. So if we really wanted to go whole hog on super detailed analysis of force production, it could be done.
Yeah, it's very exciting, and certainly.
What I also like about the box, the fourth thing I did, it's almost like a weight training session. Ray will say every time you're hitting it, it's like lifting a little weight, and so you're like doing hundreds of these in a session.
Yeah, there's research to support that, actually. A martial arts study concluded that the equivalent muscle contraction intensity, as measured by maximal voluntary isometric contraction, it was around about 60% of maximal intensity. So every punch, the level of muscle contraction, when the arm goes out, the fist clenches, the arm braces, you're approximating 60%. So imagine you could lift 100 kilos on a bench press. Well, then each punch is somewhere in the vicinity of the intensity of a 60 kilo bench press.
Yeah, and don't you sort of work up to about 80, and that's about where you sort of do your reps and you.
Yeah, so there is definitely some credibility, or certainly some evidence to suggest that punching is a form of strength training, or at least can elicit similar benefits.
Yeah, and look, I have to say I'm very excited about the whole data on strength training and cognition. There's some excellent work from Daniel Korkos, an American sports scientist, that looked at Parkinson's and resistance training and showed improvements in cognition and even cortex thickness. And there's stuff, I think, more generally about in older healthy adults, it being a more effective impact on cognition and cardiovascular performance than aerobic training. So I think that's a very exciting aspect to exercise modality. But I should also mention that, with Parkinson's disease, this is just one component of a training program. There was an excellent statement by the American Parkinson's Foundation and the American College of Sports Medicine in 2021 that divided different modalities into aerobic, strength, balance, and flexibility, and summarized what data was available in terms of intensity and frequency. And so it's a mixture of all those different things that I think is important. I do a lot of yoga, and I find that a nice counterpoint to the boxing. Helps us do the yin yoga variety, where you do a lot of deep stretching. I find that a good counterbalance to the tight muscles afterwards. So,
Yeah, I guess the analogy could be similar to that of the food pyramid or healthy eating guidelines, that you want to eat from a little bit of every food basket, not just one food basket or one food group. And I think that message about Parkinson's is very, very well aligned, that we don't want to put all of our focus on one exercise modality. It's the combination of a few, just like the combination of different food groups leads to healthier eating.
It's very good. And when you think about it, most of these patients are getting older, and stuff happens, and you have to be prepared to modify. You know, if you've got some injury and you can't weight bear, then you can do some more upper limb weight work, or you could do seated yoga, or you could do seated boxing. I've had I had a retinal detachment a few months ago, which has nothing to do with boxing, just spontaneous. So I had to quite modify a few things to avoid raising ocular pressure. And so there's always some sort of modification that needs to be made. And, my wife, who's actually a nurse and midwife, she's undertaken a couple of yoga courses and therapeutic yoga. And in the same way, Ray and I designed a very Parkinson-specific boxing thing. We're trying to do a Parkinson-specific yoga course as well, which would be a nice supplement to this whole program.
Absolutely. So I guess there's a lot to be excited about, but I also think we need to consider how we move to best practice guidelines for exercise professionals, and not get too carried away and see this as a panacea of some sort. So some responsibility as well. So could you allude to some recommendations you might make to exercise professionals who are considering running their own boxing class for individuals living with Parkinson's disease?
Well, what we've tried to do is start the bar focusing on feasibility and safety. And we have some caveats drawn into this. In our educational videos, we really recommend that they all do go get a proper health check, cardiovascular risk screening, osteoporosis screening. And I actually found that quite a useful thing, because often when the patient's diagnosed with Parkinson's disease, there's a degree of discomfort of general practitioners, I think, managing neurological conditions, because they can often be quite daunting. But the general practitioner is the expert in those cardiovascular screening and osteoporosis management. And if I've got a new patient, I'll get them set up with their Parkinson's medications. But I really get them back to their GP to make sure they get really well checked out before we embark upon exercise. And it gets the GP much more engaged and involved. And I kind of like to build that relationship through the avenue of exercise. So, as I said before, there are recommendations from the American College of Sports Medicine, but when it comes down to national guidelines about exercise, they're still very, very vague in terms of the definitions, and certainly we still need to build on this.
What advice might you give someone? I guess there'll be a lot of exercise professionals who haven't had the experience of working with individuals with Parkinson's disease, and when they've actually got them on the floor doing some boxing, what are the things they should look out for, and how can they ensure safety and make sure they're monitoring them well enough to pick up when it might be time to give them a rest or they're overdoing it? What are the things to look out for that are Parkinson's specific?
So a couple of really basic things. You want to probably exercise them when they've got their dose at the peak. So you want to get them timing their dose, so it's absorbed and blood levels coming up. So you want to be exercising at the optimal dose time. You want to be aware of postural hypotension. So one of the features, particularly in later Parkinson's disease, is autonomic involvement. So you can get postural blood pressure changes by the disease and by the medicines. And I heard you talking earlier, and one of you talks about heart rate variability, and that is an interesting area. So a little bit of care with the head up, head down, need a bit of time. Want to make sure they're close to the toilets, because they often have decreased control of bladder and bowel as well. So you want to have a few practical things lined up. And then probably the most important thing is balance. So one of the sort of cut points in the progress of Parkinson's disease is when it becomes bilateral and you start to lose some of your balance reflexes, and there's a tendency to sort of fall backwards. And so, so if we're kind of at that balance phase, you really probably need to have a support person or someone there. We've modified some of our boxing programs. So a lot of the boxing movements in and out. As you're going backwards, you can be predisposed to keep going backwards and falling. So as an alternative, we sort of get them to grab onto the machine and then do some slightly different sequences. So the balance and falling backwards is really one to be very careful and watch for.
How important would some pre-screening around or assessments like the push and pull test as part of the mini best? I noticed that's a clinical measure. It's part of the mini best battery.
Yeah.
How sensitive would that be in terms of just wanting to make sure that you've got the person doing the right activities in the class, or grading and modifying certain activities like you've mentioned, where you might be having them doing some footwork where they are coming in and out of a target?
Yeah. So I think there's a bit of a balance between the safety aspect, but also the challenge of potentially improving on that balance throughout the course of things. So that depends upon your ability to supervise. So we had the luxury of having, it was almost at any given time we'd have a couple of students there. So it was almost 1 in 2. So if you're running a class and you've got less hands-on, you might have to take account of that. But if you've got a support person right there ready to help, you could perhaps be a little bit more bold.
Can I ask what outcome measures you used in the study? And these are something for exercise professionals to think about, but it's helpful if they can do pre and post assessments just to monitor the effectiveness and keep modifying the dose if there's improvement or not improvement in certain outcomes. Is there any you might recommend?
So for so we use there's a standardized tool called the Unified Parkinson's Disease Rating Score, or UPDRS, and it's a 4-point item with various different sub-bits, and there's a motor component that is the most commonly used, and this is all non-blinded, and but we did it before and after, and so we made sure that was done at the same timing according to dosing. So one of the things that when you're measuring Parkinson's outcomes, you have to be a bit careful about, are you going to do it at the peak of the dose, or are you going to do it 12 hours off dose, because that can make an impact. And we found that 9 out of 10 participants had a significant improvement in their pre versus post. But because we've de-emphasised that, because it's obviously not a phase 2 study, high-level study with appropriate power. But so in answer to your question about specific disease measure, UPDRS is the one used for Parkinson's disease. We also used some basic Likert scales for sleep, fatigue, and pain as well. We close watch on those. And we also looked at the percentage of time spent at various different heart rates. So we've got some graphs looking at the, and in fact, Travis tried to design the program to ease them into it a little bit more at a moderate level. And we actually found that they were so enthusiastic, they jumped into the heart rate zone a bit higher than we expected in the first block. I think we perhaps had selected people who are keen and a bit anxious and
it doesn't take much for punching to get the heart rate elevated and to exceed that 70%. I think from memory, when I recall in your program, the first block was 70% of maximum heart rate, and that's very easy to.
It's pretty easy to
30 seconds into a 2-minute round, and you're usually well above that. So depending what target it is, you're hitting that, of course. So I can understand the practicalities of heart rate monitoring.
Well, what we did actually find was that there was a really tight correlation between the, I don't think we actually put it in the paper, but we correlated the ball scales versus the heart rate. And in some of the previous cycling studies, there's been this question about whether or not the ball was a valid measure in Parkinson's because of that autonomic neuropathy. But you may have heard of Jay Alberts in Cleveland. He's done a lot of stuff on cycling. And it's and particularly forced exercise with cycling. And, so he's done a lot of really interesting studies. That forced exercise concept that he developed on a tandem bike, where the Parkinson's patient had to amp up their cadence by about 30%, seemed to be the zone where they really started to get benefit. And, that kind of matches some of the animal studies, actually, is it? And I think that probably ties into what I was saying before about thresholds that will trigger various central changes in metabolism in a favorable way.
Yeah, so interesting. Well, look, it's approaching the hour mark, and I'm mindful of your time and not wanting to steal too much of it. I feel as though I could have this conversation for a lot longer. I feel like it's appropriate probably to start wrapping things up. So I guess I would like to ask finally for listeners or anyone who's got Parkinson's experience, what advice would you give them from this lived experience that you've had and some of the findings of your study?
That really exercise is probably more at the start. It's probably more important than medications, and it can make you feel better and get you to take charge. When I see a new patient, I give them a list of physiotherapists who have expertise in Parkinson's disease. So I'd get a physiotherapist on your side who's an expert in Parkinson's. I'd probably get a personal trainer or a exercise physiologist as well involved, and I get going on a program. And things can be individualized. You don't all have to be boxing. There's other things that have got some good data, such as dancing, and there's actually a fairly good similarity between dancing and boxing when you think about the movements.
Completely agree.
Apparently was a very good dancer. So you take away some of the strength bits, but the agility and the balance from dance. Yoga and Tai Chi have also been shown, and simple brisk walking. So I didn't get to mention it, but there are 3 small phase 2 studies, one of cycling, one of treadmill walking, and one of brisk outdoor walking, all of where high intensity over moderate intensity was demonstrated to slow that UPDRS progression that I talked about before with the measures. So there's a big phase 3 study called Sparks 3 of treadmill exercise that's almost complete in the US, probably coming out next year. That's looked at that further and will give us further data. So all those simple things.
Yes. Yeah, absolutely wonderful advice. Well, Professor Blacker, thank you so much for coming on our podcast and sharing those wonderful insights and very informative discussion. And I'm sure everyone who's listening to this podcast or has listened to it will gain as much as I have out of this conversation. So thank you so much.
No problems, Luke. I think you're doing a fantastic job with this too. I think it's been very helpful. I think a lot of people have benefited from your work.
Thank you.
Okay.
All right. So